next guest speaker, Dr. Nishit Choksi, who is also my mentor at William Beaumont Hospital. He's been one of the best interventional and peripheral interventional cardiologists I've known over the last 30 years. He graduated from Grant Medical College, Mumbai, and trained everything at William Beaumont Hospital in Michigan. Again, he has a number of honors. He was recognized by both United States as well as in India, multiple awards, multiple publications, and he was part of all the studies what Dr. Grimes and Dr. O'Neill were doing at Beaumont Hospital. And he's been a greatest peripheral interventional cardiologist I know. And thank you, Dr. Choksi, being a great mentor over the years. And then Dr. Choksi is going to talk about the pulmonary embolism treatment in a percutaneous route. And he has so many innovative ways he can do the procedures, both peripheral, cardiac, and now in the pulmonary circulation. Dr. Choksi.
Thank you, Srini. Thanks for giving me the platform to talk on this TCT conference. My topic for the day is management of pulmonary embolism, which, like acute myocardial infarction, has come a long way from intravenous lytics such as streptokinase, urokinase, TPA to what we do now, acute angioplasty, thrombectomy, and angioplasty. The same thing has happened in the realm of pulmonary embolism, where we used to treat patients with IV heparin. Unfortunately, even today, majority of the patients are just treated with IV heparin. But we have come a long way. We started giving IV lytics, catheter-directed lytics, and now we have come to a newer technology, which is thrombectomy, and I'll allude to that in a little bit. DVT was first recognized by one of our own physicians, Susulta, back before Christ, where he has documented that he saw a swollen, painful leg that was difficult to treat. And fast forward in 1761, Giovanni Battista recognized clots in the pulmonary arteries after sudden cardiac death, but he didn't quite make the connection between the two. Fast forward 1846, Warshaw described detachment of larger and smaller fragments on the end of a softening thrombus, which are carried along the bloodstream and driven into remote vessels, i.e. pulmonary circulation. And he gave that process a name, which is embolia, which we now call embolic phenomena. So a third of the patients with DVT will develop...
Dr. Choksi, are you sharing the screen? Do you have the slides? You're not sharing the screen.
I'm sharing the screen, yes.
It's not coming through.
Okay. The patients with DVT will develop symptomatic PE. Unfortunately, within an hour of PE, 11% of the patients will die. So it's a very lethal condition and something that we need to, one second, I can't go forward now.
I'll just click enter.
It says my screen is paused by the...
You came out of the sharing again.
Yeah, but my screen is paused by... Can you see the screen now?
Yep, go ahead. Okay, go ahead.
The screen will not move forward. That is a problem.
Dr. Choksi, at the bottom, do you see the gray arrow when you hover around it at the left bottom?
Okay, got it. So again, the treatment is going to depend on rapid diagnosis and hence improve the outcomes of pulmonary embolism. A diagnosis, as you all know, can be made very easily by clinical judgment, and of course, a variety of tests that we have in our armamentarium. There was a time early on when we were fellows in the 80s where we used to do pulmonary angiogram, but that is not done anymore unless we're going to treat the patient mechanically. Echocardiogram is done in every patient with pulmonary embolism. Mainly, we're looking at the right ventricle, dilatation of the right ventricle, systolic function of the right ventricle, and of course, looking at the left ventricle. Usually, they're small in size. The interatrial septum is flattened, and the RV dilates. Interestingly, once a PE is treated, whether you treat it with thrombectomy or with the thrombolytic therapy, the RV function may improve. And that's what we are looking for in these patients to improve their outcome, to improve their mortality. The diagnostic tool of choice is CT angiogram. Most of the patients who come to the emergency room, that's the first thing that we do is CT angiogram. And then depending upon the RV-LV ratio, we take them to the cath lab for further management. The treatment, obviously everybody gets heparin. Unless they are allergic to heparin, they may get adatrobine. Surgical embolectomy is rarely done nowadays with the availability of mechanical thrombectomy devices. Venous
Sorry, Dr.
interruption.
Choksi. I think it's still frozen. I think you can't see the moving. The screen is still okay. Now, okay. Now it's going. Okay, keep going.
See now?
Yep, now we can see. Now, yeah, keep going.
I don't know why it's freezing up. The treatment is usually pretty common, heparin for every patient. Unless they're allergic to heparin, they get adatrobine. Embolectomy, surgical is not done anymore because of availability of large bore thrombectomy devices. Venous interruption is something that we don't do anymore with the availability of IVC filters. And of course, finally, thrombolytics and percutaneous embolectomy. Long-term treatment, obviously, warfarin was the treatment of choice before the time of NOACs, but that's not used anymore. Most of the time, it's either rivaroxaban or apixaban. The definition of high risk or massive PE is very straightforward. It relies on the presence of RV failure, which results in hemodynamic compromise. About 5% of the patients who present with PE will have massive PE, and the in-hospital mortality is close to 15%. And hence, this becomes an emergency, and they need to be taken to the cath lab for further management. The clot usually comes from the legs, although one may not see a DVT on venous ultrasound when they come to the emergency room because the horse may have left the barn. Sometimes it comes from the iliac veins due to iliac vein stenosis, what we call May-Turner's or May-Turner's-like syndrome. Symptoms are very common: chest pain, shortness of breath. But some of the symptoms that we kind of tend to ignore are the patient's sense of doom and death. And that is pretty common sine qua non symptom of pulmonary embolism. Syncope is another very common symptom, but ignored because we start looking for other reasons of syncope rather than PE. And particularly in these days of COVID, PE should be kept uppermost in our mind. So what generally happens is the right heart is straining to push blood past the clot, and death is usually from right heart failure. So that's what we treat. We treat the clot, thereby improving RV function. So if the RV-LV ratio on CT and or on echo is greater than 1, then these patients come to the cardiac cath lab. The predictor is an independent predictor of 30-day mortality. The RV-LV ratio is an independent predictor of mortality. Now, I already mentioned that. So CT is something that is, as I said earlier, the best diagnostic tool of choice. We can do it before the procedure, and you can see after the procedure, you can follow up to look at the RV diameter. That can also be done by echocardiograms, a very reliable way of diagnosing pulmonary embolism. The treatments are, as I mentioned earlier, anticoagulation therapy, systemic thrombolysis that we used to do before, catheter-directed thrombolysis, which we did for almost a decade with ECOS and ECOS-like products, Penumbra, which is a smaller bore thrombectomy device, and now the Inari device, which is a large bore thrombectomy device. It's a 20 French and 24 French device that one can put in the pulmonary artery and suck out the clots, and I'll show some examples of that. The problem with thrombolytics is that there's always a concern for bleeding. We noticed that when we use TPA in our yesteryears, even minor bleeds, varying from minor bleeds to life-threatening bleeds, but the biggest concern is intracranial hemorrhage. I remember a young girl who was transferred from an outside institution back in the days, was given TPA and flown to Beaumont Hospital, and on the way she bled in the brain, and unfortunately she didn't make it. And that particular case has been etched in my brain, and therefore, using thrombolytics, we had to be extremely careful because of this ICH issue. Meta-analysis shows that major bleeding happens about 6.6% of the patients, and intracranial hemorrhage about 1.7% of patients overall. Although the registry data shows much higher incidence of both major bleeding at 21% and intracranial hemorrhage at 3.3%. So, one, thrombolytic therapy is not the most effective way of treatment because you have to remember that these clots are coming from the legs and or the iliac veins, and they've been sitting there for a few days, and therefore you'll see patients who've had hip surgery, knee surgery. They go home, they're fine. A week or two later, they come with PE because this clot has been sitting in the legs and progressing, and then finally breaks up and goes to the lung. So some of these clots are kind of older clots, some of them are newer clots. The lytic agents will lyse the newer clots, but will not lyse the older clots. The reason being, within a few days of the clot, the fibrin is quickly replaced by collagen, and lytics are not.
Dr. Choksi, I think there is a live case going to start now, so can we just close it in like 1 to 2 minutes? That'll be great.
Certainly. So I will just show some examples then of the thrombectomy device that we are using now. So this is the kind of clots we removed from the pulmonary artery. More than 70% of the clots are old collagenous clots that cannot be lysed. If you look at the data from FLASH trial, where we don't use TPA, the mortality is very low, major bleeding 1.4%, ICS 0. And of course, as you can see in the other trial, the Seattle trial, the Optimize trial, and the ICOPA trial, we did not use any they were all thrombolytic agents where there was mortality involved and there was ICH involved. I think I'll do close. I will just show some examples of this device. 17-year-old lady, 7 weeks pregnant, went in full cardiac arrest at a local restaurant, was given TPA. The fetus unfortunately died. Patient was given 100 milligrams of TPA. Hemodynamics did not change. PA pressures remained high, blood pressure low, heart rate high. We went in, removed the clots. As you can see, most of these are old clots sitting like that. The heart rates immediately improved, oxygenation improved, the PA pressure came down with lytic therapies. Let me know when you're ready for me to stop, okay? There's another patient, 56-year-old, who had PE. The upper lobe is not perfused. Here, the lower lobe is not perfused after the thrombectomy with the NRV device. You can see good perfusion in the lower lobe here and the upper lobe here. And it takes about an hour, 45 minutes, an hour to do. So here's a patient with large thrombus load, and post-scenario, you can see that pretty much most of the thrombus is gone. It's a very safe device. Mortality is very, very rare, 0.6%. Usually the mortality is due to PE itself rather than the device, unlike in thrombolytic agents where one can have mortality due to lytics itself. Data 106 patients, procedure-related major adverse event 0, major bleeding 0.9%. The other important thing with the hospitals is that most of these patients do not need ICU monitoring post-procedure unless they had ICU to begin with. Another data from 2019, 46 patients, 100% survival to hospital discharge, 0 deaths related to the device itself, and 4.3% adverse events. Another data.
If you can close in 15 seconds, that'll be great.
Are you done? Am I
15
done?
seconds. Yeah,
okay. Well, I think I'll show some other examples here. This is a patient with blood clot. The key here is to first deal with the proximal clot first, rather than going down below, which you learn from the coronary.
Spider, go to the spider.
If we do the distal ones first, you may push the proximal clot downstream, and the results will not be very good. Here's an example of the angiogram looking worse after the first thrombectomy run. You can see the distal vessels are filling up. So what we've learned is first deal with the proximal thrombus, then the distal thrombus. So I think I will stop at that. If you have any questions, I'll be happy to take. So a few other examples of declotting with a NRV device. Here are the kind of clots that you remove. Some are the newer clots, some are old collagenous clots, which obviously you can see cannot be lysed with thrombolytic agents. We usually do either some perclose closure of the groin or do a stitch at the femoral vein because the 24 French sheath and bleeding complications are almost negligible. We have the long strings of clot that we remove from the pulmonary artery. So I'll end with this. If you have any questions, I'll be happy to take them.
Okay. Thank you, Dr. Choksi. That was amazing. I think what we were doing versus what we are doing right now. Thank you for those wonderful presentations. Thank you, everyone. I know there is a next session is starting. Thank you, Srinivas Kumar, Dr. Ryan, Dr. Mahesh, Dr. Choksi, Dr. Venkat, Dr. Ram. I think it's been amazing to be participating in this TCT from India and South Asia. Thanks a lot. Thank you for your encouragement and participation.